So very good afternoon to everybody here, and I would like really to welcome you all to our last session of the day. We have an hour and a half to talk about. It's all about the lens, and I expect this session to have very heated discussion, which I would love but it will be, I think, educational for all of us. Allow me to welcome on the stage the panelists with me, Dr. Borja Salvador Kuya, and Shiraz Daya and Martin Dirisamer. Dr. Dirisamer will be the first speaker. We'd like to welcome you to UAE and Abu Dhabi, and thank you very much for being amongst us. He took the time off to come here, and really we are glad to have him. Cornea versus lens-based refractive surgery, when and how? We'll see what Dr. Dirisamer will tell us today about it. Please, the stage is all yours. Thank you.
Thank you for a nice introduction. Can you switch on the mic? Okay. So I hope everyone had some coffee and is fully relaxed because we have a very tough session over here. So my topic is cornea versus lens-based refractive surgery, when and how. So here. So first of all, I think there's not a one-fits-all solution. So there's not a decision tree where you can say this works in all cases. That's very important. So there are always some borderline cases, some individual decisions based on the patient's character and so on. So first we have to make some considerations about what kind of refractive error are we going to treat. Is it myopia, hyperopia, astigmatism, or presbyopia, or more or less all together? What is the age of the patient, the condition of the eye? Are there concomitant eye diseases which rule out some other options? For example, corneal diseases. What is the patient expectation? I think this is one of the most important things when we're talking about refractive surgery. Are there any natural or anatomical limitations? And what are the risks and complications of each approach? But first, we have to keep in mind, do no harm. So that's very important, because if we're talking about borderline cases or in cases where you might do refractive surgery or not, remember, this is what we promised, no harm. So my personal approach, if we're talking about myopia, dealing with a clear lens and an acceptable accommodation, I go either for laser vision correction. My preferred procedure is SMILE, or you can do LASIK or PRK or ICL. So similar, it's in hyperopia if it's below 4 diopters. And honestly, I do not go to 4 diopters treating with laser vision correction. My limit is 3 diopters. So if you're dealing with hyperopia, clear lens, acceptable accommodation, LASIK is probably a preferred procedure, probably ICL, but the chance that you can put in an ICL in these eyes is very low because the anterior chamber is quite often pretty shallow. And probably SMILE soon, but it's not yet available. But there are some different or difficult situation. And that's why I ask also the chairs probably to make some comments. For example, if there is a patient with high myopia, age below 50, not suitable for laser vision correction or ICL, what are you doing? So my personal approach is no surgery in these cases. The risk for retinal detachment is too high. Of course, you can make exceptions. So if the patient really shows you the demand, he really wants to do that, and you really spend some chair time with this patient, explain everything. If you're dealing with high myopia, the age older than 50, not suitable for laser vision correction or ICL, we have still a higher risk for retinal detachment and myopia-associated diseases. Never forget about that. And depending on the patient's motivation, what he really gets, what are the risks, And if he still is eager to do a refractive procedure, I changed my personal approach now to do a duet procedure, which means I put a monofocal IOL in the back and a multifocal IOL on top in the sulcus in the same procedure. We already do 4 lenses in one session, so to speak. I'll talk about it in a second. If we have to deal with low and moderate myopia, and presbyopic patients. So if you imagine one of these patients, and I first do a contact lens trial for monovision. If it's okay, we can go for laser vision correction. I do very, very few refractive lens exchanges in these patients. So the risk for an unhappy patient is here very high. So what is this duet procedure? I explained it already. So first, we put a monofocal toric or not toric, depends, in the capsular bag and put a multifocal add-on IOL on top. It gives you some kind of additional benefit, so you have some more options. If you really have to deal with a macular issue in high myops or even retinal detachment, whatever, so it might be very easy to just pull out this sulcus fixated IOL because the material is very soft and it's very easy. Here's this OCT, you can see it very nicely. And these perform similar to normal trifocal IOLs. So there is no really difference, at least not published and at least not in our hands. What are some borderline cases? Sorry for the typo here. So, as we already discussed, high myopia, which are not suitable for laser vision correction, the age between 40 and 60. ICL monovision, or do you go for refractive lens exchange? So we have this situation quite often, and we did both. And we have in both cases different or similar experiences. So we have good results with trifocals in these patients, but also with monovision, but also bad results somehow because they're not happy. What about low and moderate myopia, presbyopic, not suitable for laser vision correction, ICL, and a negative contact lens trial? Do you do a refractive lens exchange? Probably not. Ametropia, this is a kind of a patient we all know very well. Ametropic, presbyopic, and a very good far distance vision, so 20/20 or better. What are you going to do? Do you offer laser vision correction with presbyopic, advanced presbyopic profiles? Do you probably either offer a trifocal IOL? You know, some patients are really pushy to do something. So I do in this case, I'm very passive, so I send them home. What about moderate hyperopia, age between 40 and 50? Do you go for a refractive lens exchange or laser vision correction? And probably one of the most tricky situations, the high hyperopia. So the age is below 45 and high hyperopia. So what I want to point out, there are two publications, what I'm showing now. These are very bold guys who did this study because they included young hyperopes below the age of 40 with hyperopia up to plus 10.75. They included amblyopic eyes, and the youngest patient was 21. So I would never do that. I just want to show you this paper. So on the one hand, they achieved a pretty good result. So everyone was spectacularly independent. Nevertheless, 14% of the young patients were not happy with their far vision. So what about the ethical issues we have, or what are the ethical limits for refractive surgeons? I think we have to raise this question more often. On the other side, so thanks to my dear friend Jorge Alio Junior, he published, or he's very pushy that we can do laser vision correction up to 6.5 diopters. And he tries to convince me with this paper where they treated more than 5 diopters hyperopia, and they achieved a pretty good efficiency and safety index, which is comparable to the refractive lens exchanges, or the study about the refractive lens exchanges. But if you look it up, we have enhancement rates up to 30%. So this is pretty high. But he compared it to refractive lens exchange to moderate hyperopia and high hyperopia. And according to this, it is safe to treat hyperopia up to 6.5 with LASIK. Don't take a picture, please, because this is not my opinion.
Dr. Dirisamer, for the sake of time, please. Just carry on. Maybe one more minute.
It's just a few slides. So important post-op considerations. Laser enhancement rate, I already told you. Here are some different laser systems which are used. So they are all doing pretty well, so achieving pretty good results with treating hyperopia with LASIK. Just to make it short, clear lens exchange or refractive lens exchange, it's a final solution, it's long-lasting, it's a very high accurate procedure with low enhancement rates, and even then you can do it with laser or with add-on IOLs, and a relatively low risk contra. Of course, it's not reversible. You lose all your accommodation, certainly, and it's an intraocular surgery with all the possible worst-case scenarios. If you treat hyperopia, it's tricky. It's more tricky than myopia, of course. You need larger optical zones. You need larger flaps, which might be anatomically limited. You have to deal with regression. The centration is crucial. Enhancement rate up to 30%. And it's a pain, the early transient myopization, you all know this. For the refractive lens exchange, it's very difficult, the choice of IOL, but we will hear some talks, I think, later. Share time to explain all the different kind of IOLs we are dealing with. Sorry, Shiraz, I put the multifocal EDOF classification here, but you will make it clear afterwards. And there's no room for complication in younger patients. So to sum it up, the modified ablation profiles deliver good and safe results in laser vision correction. There are new opportunities, particularly for hyperops and ametropic patients, but there's inhomogeneous studies, so there are the groups, the lasers, the patients, so you could not really compare it. And consider the limits, set realistic patient expectations, and always under-promise and over-deliver. So do not promise anything you could not hold. Okay, thank you very much.
Thank you very much, Dr. Dirisamer.